This week on the BackTable podcast.
I was so humbled when I started it at Cleveland Clinic, and it was such a success that I knew I kind of just had to do a beta model and rebuild it at Ohio State. And we have seen some really interesting patients. We have seen a lot of uncomplicated patients, but those patients leave with education and they feel empowered. The big three themes were their desire for pain control, for multifactorial support, and then we see knowledge and awareness. And, that's some of the things that we are addressing with the clinics, which is really cool because it kind of matches up the needs of what patients want and what we're able to deliver.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got with me, once again, Dr. Amy Park. Amy, how are you?
Great. How are you, Mark?
I'm good. I feel like we haven't gotten to hang out in a little while. This is great. I missed you. I missed hanging out with you.
I know.
We have, once again, a great guest. This is somebody you know, but it's someone who I'm meeting for the first time, but is a friend of a friend. Dr. Lisa Hickman, who's here from the Ohio State University. She's a clinical associate professor of OBGYN and a urogyn and reconstructive surgeon. Lisa, welcome to the show.
Hi, thanks so much for having me. I'm excited to be here.
When we came highly recommended from our friend, Dr. Urbina, we were excited you were able to join us. And as we do for most our guests, we like to let our listeners get a sense of who you are. So tell us a little about yourself and how you got to where you are in your current position.
Sure. So I actually trained at the Cleveland Clinic for residency. When I went there, I was originally planning to go into REI based on some previous research I had done between undergrad and med school, but then rotated on urogynecology and just realized I loved it. I ended up staying for fellowship. And when I was a resident, actually, I realized that we really didn't have a good place or an aftercare setup for women who had advanced obstetric lacerations. And at the time, there were two really amazing groups that were doing research and had dedicated clinics in this area. One was Northwestern with Christina Lewicki-Gaup and her Peapod clinic, which you probably know. And then also at the University of Michigan with Dee Fenner. And I just wanted to learn from them. I was so excited about urogyn, and I really kind of fell into this clinical area as kind of a subspecialty interest. And I'm really excited to talk about it today with you guys. And now I'm at Ohio State after I graduated from fellowship in 2020. I joined as faculty and have been there ever since and keep taking care of urogyn patients and this kind of subspecialty population.
That's great. And I feel like Christina Lewicki-Gaup was at University of Chicago before I was there as a resident, and then she went to Michigan. And I think she's part of the reason they let me come, because she was so great. And they're like, those University of Chicago people must be okay, because she was so amazing. And so then I got to go, and so I feel we've kind of chased each other, but I never really got to hang out with her. So one of these days we'll have to get her on the show.
She's amazing.
It was with Dee Fenner at Michigan where I saw the first ever postpartum clinic. That was something I had not ever seen before. So that was pretty amazing.
Yeah. I mean, I had the opportunity when I was a resident to actually go up to the University of Michigan and shadow in the clinic and see kind of what their model was. And they were really formative as I developed my own at the Cleveland Clinic.
This is something I saw it develop in the field because Christina is actually a good friend of mine, and watching the work in this space, it's really amazing how much has been elucidated just in terms of the physical changes, the emotional impact, all the things. Can you just share some of your insights on what are the sequelae of pregnancy and childbirth, and how does it affect the pelvic floor? What is the pelvic floor? Just really basic questions.
All right, well, let's start with the foundation here, which is the pelvic floor. I mean, the pelvic floor is a bowl of muscles. The levator ani are the, kind of the buzz muscles that people typically know. And they are a bowl of muscles that attach to the bony pelvis and support the pelvic organs. And when they are not functioning like they're supposed to, we get pelvic floor disorders. I think that this area, peripartum pelvic floor disorders, advanced obstetric lacerations, has a really natural leaning to urogynecology. And I mean, really, during pregnancy, it's kind of the first time that women even think about their pelvic floor. 80% of women will have frequency and urgency pretty early in pregnancy. Lots of women have urinary incontinence for the first time. And so it really makes sense that we should have kind of be an influence in this area.
No, I was just going to say, like, what does pregnancy even do to the pelvic floor?
Well, I think that's kind of a complicated question. We know, obviously, changes in the hormonal milieu affect pelvic support. I mean, there are studies looking at nulliparous patients throughout pregnancy, and, there is naturally increasing laxity in the pelvic support and even some low-grade pelvic organ prolapse. The changes in the hormonal milieu that relax the muscles can also affect continence. And so all of those things together can contribute to some mild pelvic floor disorders during pregnancy. But most of the time, I think patients just assume it's a natural part of pregnancy, and it is, but it's still pelvic floor symptoms.
And then how does childbirth affect the pelvic floor?
That's a great question. So, I mean, childbirth in and of itself, there have been some actually really great modeling studies out at the University of Michigan with Dr. Delancey looking at the stretch of the levator ani muscles during delivery, and they stretch over 200%, the medial levator ani muscles. And that stretch increases as the fetal head diameter increases. And so, there are stretch injuries of the pelvic floor. There have been studies looking at nulliparous patients compared to primiparous patients, and up to a third of patients can have levator ani avulsion on imaging studies. And then there's also nerve injury. We know that the branches of the pudendal nerve can have stretch injury during delivery, and the stretch to those branches exceeds what we have seen in animal models that can cause permanent damage to the nerves. So, I mean, there is real impact on the pelvic floor and its innervation during a vaginal delivery. We know that up to 80% will experience a laceration at the time of their delivery. So there's direct injury to the pelvic floor muscles, specifically, most commonly, those that convene at the perineal body. And one area that has been a real interest of mine is advanced obstetric lacerations, 3rd and 4th degree tears. And we know that there can be some pretty significant sequelae that happen postpartum from those tears.
So tell us a little bit more about those tears. Like, how do they occur? What can we do to prevent them? I mean, I think a lot of people don't even realize when they fill out their birth plan that could even be a possibility. But like, there's forceps, there's vacuums, there's higher order tears. Just tell us what like the risks are with all the modes of delivery.
So, I mean, we know that there are some pretty well-defined risk factors for more advanced tears during delivery. Operative vaginal deliveries confer the highest risk. When you put a midline episiotomy, in addition to that, it increases the risk even more. Larger babies, typically in studies, it's more than 4,000 grams at the time of delivery. Occiput posterior position because the fetal head diameter is increased. Asian ethnicity is actually a risk factor for an increased order magnitude of tear.
You know why that is? That is because it's a shorter perineal body. Speaking from personal research.
Oh my gosh.
Like, I actually didn't know why. And then it just has to do with just the anatomy of it. It's like, it's like a safety zone. And if it's like 8 centimeters, you probably aren't going to have a 4th degree tear. You know what I mean? Or if it's like 2.5.
Right. 2.5 and less has been what's, typically quoted. And yeah, I mean, if there's less anatomic distance to traverse before you're in the anal sphincter complex, then, you're more likely to have the tear definitely.
What are things we can do to prevent it? I mean, sometimes things just happen, right? But like,
right.
Is there anything we can do to prevent these higher magnitude tears or levator avulsion during childbirth or whatever? Like, what are the things we can do to prevent this? Do some more core, like go to Pilates and bar, or what?
I think having pelvic floor awareness is a really interesting concept. I don't have any data to support that specifically, but, the physical therapist will talk about proper pushing mechanics. And that's something that when I send patients in pregnancy to physical therapy, something that I'll tell them that they can work on with their physical therapist. But as far as like what research studies have been done in the past to look at reducing severity of tear, we know there are a few things, right? So perineal massage, patients can do that starting in the 3rd trimester. You have to do it pretty regularly. But the idea is that you increase the elasticity and the stretch of that tissue so it's a little bit more compliant when it comes time to have a vaginal delivery. Warm compresses in labor have been shown to reduce the risk of having a higher order tear. I know when I was a resident, there was a lot of focus on perineal supporting the perineum during pushing and during delivery. There's a little bit of data on sideline pushing. And then ultimately, if you have someone who you're really concerned that they have maybe a short perineal body at baseline, you could consider doing a mediolateral episiotomy to offset that trajectory of force away from the anal sphincter complex. Those are not perfect. They can be more painful. They can be bloodier to repair or associated with wound healing issues. But if you're really trying to avoid that vector of force toward the sphincter complex, that's an option.
I just saw a study that maybe it's still in abstract form, but it was how to push. And if it was like short sort of pushes versus sustained pushing technique, I can't remember which one is better. I just did a
kind of important piece of the puzzle here, but yes.
I know. I can't remember which one it was. I just tried looking it up really quickly online, but I think that's a big question about technique. Like, how you're saying about the pelvic floor PTs, because it is a question mark. I would assume it's like a sustained controlled one, but I don't think people have control over it really, when it comes down to it. But it is interesting. And I wonder about technique, because that's like one of the only things you can control during labor, pushing,
right?
And the massage, essentially, which the massage, I don't know if that changed, but I mean, Mark and I are going to like show our age. I don't think the residents did that. Like, you'd have to get midwife or doula to do that probably. And I don't even know if the doulas get in there. Do they do that now?
Well, I think it's supposed to be the patient initiating.
How are the patients supposed to do it? They have an epidural a lot of the time.
No, starting at like 32 or 34 weeks. Like doing it at home to really start increasing but that is like a commitment. You have to be committed.
Well, I think committing to that, understanding the outcome of not doing that or the potential consequences, rather. Amy and I are both recovering obstetricians, but I think we probably have many memories burned in our minds of spending a lot of time at the perineum trying to figure out ways to make it less challenging of a repair for the patient's sake, obviously.
Right.
But, I think about all the different ways people told us to protect the perineum and those things. The other thing that was always like, holding the perineum almost together, like supporting it with a little 4x4 was something else I always was taught to do. And I didn't have that many big repairs, but episiotomies were something that it was definitely like in the time where like definitely do them and then definitely don't do them. You mentioned that mediolateral episiotomy. Like I said, it's been a long time since I've done obstetrics. Is that something that's been pretty well established, that sort of, in a sense, deviating or changing the angle of the tear is going to decrease the risk of getting a 4th degree? Is that something that's pretty routinely done?
I don't think it's routinely done, but I think I don't do obstetrics anymore, but I will oftentimes counsel women antepartum about who have had advanced tears in the past. And, it's like, what were your risk factors? And I like to categorize them as modifiable and non-modifiable risk factors to understand, okay, what were your risk factors when you had your first delivery with your advanced tear? And then what is still going to be a risk factor this time around, and what could we reduce the risk or won't be a concern? And for many of these patients, we know that when given the choice, 65% of women or more would pick another vaginal delivery in the future. But I think sometimes the discussion isn't like a binary decision of C-section versus vaginal delivery. It's when you would stop the line. And so having some of those strategies really, I think, empowers patients to feel like, okay, these are some things that are in my control, and this is what I'm okay with this go round, but like, this is what I'm not willing to do again. And those are nuanced decisions, and they're ones that I 100% engage the obstetrician in the discussion, because I think it's really important to take a team-based approach here. I mean, I'm not going to be in the delivery room or typically doing the repairs. So, and these are really difficult situations most of the time.
Yeah, I think that is one of the things that is really hard to say. I mean, I saw one of my neighbors actually in DC, and she did VBAC, and she developed prolapse and incontinence. And she told me, had I known I could develop this, I would have just gotten a repeat C-section. I never would have done a trial of labor after cesarean. So it's just like one of those things that people don't think about when they're counseling, because there's so many other things that people have to think about, you know?
One of my friends who's a urogyne said, I will not have a vaginal delivery. I mean, she was like not interested in any way in having a vaginal delivery. Obviously, she's she sees a lot of the consequences of that, but was not being dramatic about it. She just said, well, if I can avoid it, then I should. Not that C-sections are without their own series of potential complications, but to her it was very important, and I know that her obstetrician was happy to do it.
I also had elective C-section. You had vaginal though, right, Lisa? I would say, actually though, probably if you surveyed urogyne, maybe this is a research idea, but
that's would be so interesting.
If you survey most urogynes actually do have vaginal delivery, is what I think. I think we have a higher rate of elective C-section compared to the rest of the population, but I think the majority, and that's all relative, but the majority still have vaginal deliveries. But I will say, like, elective C-section on demand was a big deal. I was just thinking about this in the car the other day. Tony Visco went to NIH and to push for this, and essentially I think the obstetricians just were like, no, because I mean, higher order C-sections, you were talking about 5-Pete, I mean, that increases the risk of a creta, increta, percreta, all the things, bowel injury, you name it. As a public health perspective, I agree. When you talk about a quarter of the pregnancies in this country are unplanned, maybe those numbers have budged, but usually it's been about the same. And then you're talking about all these unplanned pregnancies and then setting forth this path of repeat cesareans. I don't think it makes sense from a public health perspective, but like on an individual level, it seems to make sense. So it's like sometimes these things kind of diverge, but you have to be committed to birth control and not having lots of deliveries. Although we do have 5-Petes and they do fine, but it's just not a strategy. Like in Brazil, everybody's getting C-sections, right? But that's not necessarily a good thing, I think. So I don't know. I feel conflicted about it because it's good for me. It's not good for somebody else. It sounds elitist or wrong in some sense.
But I think there's information asymmetry in medicine. There's nothing we can say about that. The same way as, like, I don't care how many times a guy fixing my car tells me about it. Like, he just knows way more. You guys have a level of understanding of a complex thing that it's really hard to communicate to truly understand what that means, at least when you're making a decision about yourself and your own body. Yeah, I am, Amy. I would be fascinated to see the results of that survey, because I've heard it from more than one urogynecologist, and no other non-medical people have ever said, oh, I'm just going to do that. Like, not one.
Yeah, I mean, I think Victoria Beckham brought all of this kind of the national media with the whole being too posh to push. And I think that term was coined from her. But, previously, I think it really had been kind of that all women should be expected to have a vaginal delivery. And I think there is a lot of merit to that. And I actually was induced and ended up abrupting and having a crash section, and the only way that a healthcare professional could do. But this was a decision that really, was one that I considered very heavily in my first pregnancy, because I knew I was the only one that could make such an informed decision about what was right for me, as you were saying, Mark. And I did think if, we have multiple children and then I end up on the, accreta spectrum in a subsequent pregnancy, I would have been so disappointed that I didn't give it the old college try. So, it is such a nuanced decision, but it also is, I think really important that we do patient-centered care and discuss really risks and benefits with them. I mean, Another shout out to Christina Lewicki-Gaup. I know when she was at Northwestern, she really made a lot of inroads with the way that they counsel patients about obstetric delivery and operative deliveries and the risks associated with that. Because in her clinic, she kept hearing patients say, like, gosh, no one told me about these risks. And these are the things that I hear in my clinic too when I see women who have had a third or fourth degree. They come in, with fecal incontinence, a lot of pain, wound healing abnormalities, and they say, gosh, no one told me these risks. Now, ultimately, we all know in healthcare, there's no way to counsel patients about every single risk, especially when you have a full clinic day and patients back to back. And again, these are complex discussions, but I think that this is where you really should meet your patient where you're at and find out, like, what are their concerns? What do they know? What don't they know? And that's where we maybe also leverage, the fact of kind of some standardized processes, which is what I think Christina was pretty successful with.
No, I agree. I think it's something that so much, and understandably and probably appropriately, so much about pregnancy is focused on the pregnancy, the fetus. Everything needs to be a certain way to make sure this thing turns out the way we want it to turn out. I don't know that I remember hearing a whole lot about the pelvic floor or mode of delivery for a patient who was in their first pregnancy. It just wasn't really part of the conversation, at the very least, bringing awareness to that conversation. And that was something that, working with Dee Fenner in her clinic, describing labor as a sports injury, right? We tear muscles and all these things happen that in sports you would go have surgery or you would go, but these things impact their lives in such profound ways that, there's no discussion before. There's more so now because of what people like you are doing, which is not as common as it needs to be. But the discussion afterwards too, though, bringing awareness to the issues, the impact of labor postpartum too. And I think about, I worked at the VA and I would see patients that had urogyne issues and stress incontinence. And I was like, oh, well, let me refer you to my colleague, a urogynecologist. And like, wait, that's something you can fix? These are like young women, like, 30s, 40s, like, I'm like, yeah. This is something that, like, there's people who specialize in this. Like, that's their whole job, is to, like, help people dealing with the problems that you're dealing with. And she's like, oh, my whole running group, we just put on pads. It's like, we just all talk about how this is going to happen the rest of our lives. I'm like, well, actually, it doesn't have to. And they had never heard of a urogyne or pelvic, whatever. We joked about it earlier, but whatever you guys are calling yourselves these days. But they'd never heard of urogynecology. They'd never heard of solutions to leaking. It's just kind of thing, oh, my mom said this is just what happens when you have kids. So the fact that you're bringing awareness, that you're putting these clinics together, is so important for patients to know that this is something that's very common, not normal, but exceedingly common and oftentimes undertreated.
Yeah, what kind of things are you feeling or are you seeing in your clinic? Like, I just remember when I first got here in 2020, you and Katie Props it was your passion. You worked with her to stand up this clinic. So in addition to the things that you're treating, you were obviously addressing and closing a gap, but also what were some of your insights into standing up a clinic both here and at Ohio State? I know there's a lot of questions there, but I'm just curious because there's a lot of stuff that you have to address.
Yeah, those are great questions. So, the model of the clinic that I started at the Cleveland Clinic, which is the postpartum care clinic, and it still exists today, is that we would see all patients who had third and fourth degree tears during delivery at a short interval, which is really in line with what ACOG has recommended, that women who need postpartum care at a shorter interval, whether that's a touch base, an appointment with a midwife, or an APP. And so we wanted to see these patients early postpartum because we know that there's a high incidence of wound complications. Wound infection can happen in about 20% of patients who have third and fourth degree tears, wound breakdown up to 25% of patients. And then, pain, acute pain is a pretty significant issue for these patients short term. Some patients do, transition into some long-term chronic pain after these tears. Other things postpartum, we know for this patient population, there's a high rate of fecal urgency, up to 30% of patients, but it's probably honestly even more than that from what I anecdotally see in clinic from talking to patients. Anal incontinence can be as high as 60%. So incontinence of flatus or stool. And, that is a sequelae, I think, that psychologically really affects women because, they really only ever imagine that one person in their household would be in diapers after they have a baby and that it wasn't them. Rectovaginal fistulas is like an instance of 1% to 2% in this patient population. But if you see enough of these patients, you will for sure be taking care of complex fistulas. I actually just took care of a woman who had her second baby, second-degree tear with her first, and she had a breakdown of the perineum that connected to the rectum. So it was a rectoperineal fistula. And, it was totally unanticipated, especially given that she had had a second-degree tear in her last pregnancy. More than the incontinence, more than the prolapse. I mean, dyspareunia can be a big issue in this patient population. And then the psychological impact and the PTSD that can come from a traumatic delivery. I mean, talking to patients, I have patients who say, like, there is no way I can have another vaginal delivery. I already decided we need to adopt because if someone is going to make me have another delivery vaginally in the future, I just can't do it. And so I think it's really important to create a space. These visits are a lot of education. When you see them early postpartum, there's a lot to kind of unpack. But we make sure that they're on a bowel regimen. We address pain control issues. We are screening them with the Edinburgh postnatal depression scale to evaluate for any kind of early postpartum depression and anxiety. And then it's a lot of education of what happened and why did it happen, what was involved, and what does it mean for the future.
Yeah, that is a lot of stuff. I was just going to say,
it's a lot.
Do you have a social worker who works alongside you in pelvic floor PT, or you just refer to them, or how does that work?
I would love to have a social worker. I think that there's a lot that we could do there, but unfortunately we don't. So, I get creative with my resources. I mean, we have great teams of people that I can refer out to for depression, anxiety, things like that. We work closely with lactation if patients are struggling there. And then we actually do have an incredible pelvic floor PT department at Ohio State. And we set up tandem appointments for patients. So they see me and then they're able to go see physical therapy the same day. And even if they're not ready for full-blown pelvic floor PT, the physical therapists and I and many other experts in this kind of area feel like early intervention is where it's at.
I was going to say, and also the access about the mental health. I had this patient who had a 4th degree after a forceps. The thing kept on breaking down. She had a multi-drug resistant bacteria grout. I couldn't get it. Remember I called you about this lady?
I do remember.
She was a dentist. She became my dentist. And then she's like in my teeth. And then she's like, do you remember me? I was like, are you sitting okay?
Gosh.
But anyway, she endorsed suicidal ideation. And then we put in a stat consult and it was March. They did not get her in until July. Like, this is not right, and this is not an uncommon thing. Like, you guys aren't even surprised about this, right? Like, it's like terrible.
But you know what? I mean, I have people I can tap and say like, hey, I really need help with this patient. And thankfully, I've created this nice little network so that we can really make some pretty quick inroads if we need to for a new mother.
So can you talk about building that clinic, though? I think there's things that make it challenging. Obviously, having a urogynecologist who, or at least somebody who is interested, aware, educated in this postpartum, peripartum complications. But does this fall under, just like a billing question, does this fall under the global billing period for obstetrics? And is this a special separate issue that you can bill separately for as a consult? Like, how, when someone's building a clinic like this, what are the things they need to think about or know about?
Yeah, those are good questions. So I actually had the pleasure of writing a paper on starting a peripartum clinic that you can find in the Gray Journal. And it was a collaboration with Katie Probst, Carolyn Swenson, who's now at the University of Utah, and Christina Lewicki-Gaup. And we knew that this is kind of an emerging area that people have had growing interest in. And so we wanted to kind of have a roadmap that people could reference on, here's what you need to know to start a clinic. And I think the first thing is a lot of planning and understanding who the stakeholders are. I mean, when I was designing this clinic, I felt like I went on a PR tour. I mean, I gave grand rounds at both hospitals that we did deliveries at Cleveland Clinic. And I wanted to make it very clear that this is a team approach, that I am not Monday morning quarterbacking, what is done in the labor room. In fact, I am the biggest advocate for obstetricians. I think that they have an incredibly challenging job when they do these repairs on tissue that is incredibly edematous. They are working in not the most ideal lighting or not the most ideal instruments, and they have 20 other people on the labor board at the same time who need their attention. And so, I think just making it very clear what the mission is and how you are going to work in tandem with them is really important, because you will really get allies. And this totally became like a Field of Dreams situation. Like, I built it and they came. And I think a big infrastructural thing that made a huge difference is that we created a best practice alert in the EMR, so that anytime a third or fourth degree repair was marked in the delivery record, it prompted, like, would you like to refer to this clinic? But then we also created an infrastructure so patients could also be referred if they had complex wound breakdown, if they wanted to be seen antepartum for prolapse or urinary incontinence, or if they wanted to be seen postpartum for some other pelvic floor issue. There was kind of a freestanding order. We do bill these as new consults, and I have not received word from my billing colleagues that it, hasn't been paid out like that. So that's kind of the model that we've taken. And then, I think that there's a lot of low acuity for many of these patients. There are lots of patients who have tears that heal beautifully and, once they get past the initial period, don't have any pelvic floor complaints. And those are great patients that you could team up with an APP who you train. And that's exactly what we did at Cleveland Clinic. Abby Anderson was amazing, and she still is seeing these patients. And in the beginning, she would just come see patients with me, got the hang of it, learned the counseling, because a lot of it, like I said, is education. And, you really could team up with an APP. And it's a great service for patients.
It's a huge service, and there's such a gap. And the other thing I will say on the back end that I know was a big deal is getting a nurse navigator. Now, I don't know how many urogyne clinics can have a nurse navigator, but here at least we have 2 actually, and it really helped to triage these patients. The other thing is it's sort of the initial referrals kind of got, our nurse navigators used to take care of it, but now there's somebody who actually screens all postpartum. I think I can't remember exactly what bumps these patients up into her sort of sphere, but she is helping with triaging because there's just such a huge need. And then she will triage the low acuity from the higher acuity, because routine, sort of postpartum
Hemorrhoids
or sexual dysfunction can go to pelvic floor PT without needing urogyne, you know what I mean? And some vaginal estrogen, but then a lot of other people need a little bit more care. And a lot of people just need some PT period. I mean, I see a lot of stress incontinence in that clinic too. I see a couple of those patients, and I mean, honestly, I don't know the percentages, but a lot of people have postpartum stress incontinence and it goes away in the first year. It's 60% or something, right?
It is very high. I mean, and that's another good point, is we know the natural history of many of these pelvic floor issues postpartum. And for most of them, by 3 months postpartum, so if you can get patients past that 4th trimester, it will be significantly improved. And some of the other kind of studies that follow women out, there might be interval improvement between 3 and 6 months postpartum, but truly once you get to about 6 months postpartum, probably what you have is what it's going to be. But I do think that that's a really interesting point you make, Amy, about the role of physical therapy after obstetric delivery. And that's something that I've been also super interested in. So, obviously pelvic floor physical therapy is a limited resource, and getting every woman in for PT would, I think, overwhelm at least our system at Ohio State. But one program that I started at Ohio State, which is now actually up and running, is called Smart Start to Motherhood. And I got a grant. And basically, Smart Start stands for Supplying Medical Knowledge and Rehabilitative Therapy. And we made high-impact patient education videos that everyone who is enrolled at Ohio State has access to during their pregnancy. They get access to them in the 3rd trimester. And it's all topics that women tell me they wish they would have known. So bowel and bladder control issues in pregnancy and postpartum, sexual dysfunction postpartum, sexual pain and changes in desire, postpartum mood disorders, the pelvic floor and what it is, obstetric lacerations, things like that. And then as part of the program, we have group pelvic floor PT classes that anyone who has a delivery at OSU has access to go to. So, at least you get in a group setting and can learn some basics of how to use your pelvic floor and contract your pelvic floor. And if you really feel like you need more than that, then you talk to your obstetric provider and you can see, about getting a referral to go back and do one-on-one therapy.
Yeah, I mean, it's incredible. And one of the things I noticed when I came to the University of Kentucky, there wasn't a huge PT program, and there weren't a lot of therapists. We see a lot of folks from outside of the city, and so they're going back to their small towns. But we would just continue to write referrals, and they would go to these local PT places or hospitals. And now there's probably a dozen in hospitals and places around the state that they just kept getting referrals from us. They said, I guess we should probably hire somebody. And so we've got like a network of PTs that went and got training and realized the hospital saw that there was a need for it. So sometimes just educating patients and having patients demand it where they are, because it's not something you can drive 3 hours for, multiple times a week. It's one of those things that it's a slow build, and it's a community build more so even than just an institutional build, but something that is such I obviously take care of a lot of pelvic pain, but I'm a MIG surgeon, but so much of what we do is not my surgery or my prescription, but it's the expertise of our pelvic floor PT colleagues. And I just can't imagine caring for these patients without them. I mean, it's really amazing.
It is a little structural difference, though, about pelvic floor PT, because just like peds urology or peds in adolescent gynecology, it's like you get more training, but it's not like you get paid more for this extra training. So you have to do all this extra certification. You have to get a private room. Has to be, there's all these things that go along with being pelvic floor PT. And then you can't see as many patients or whatever. And so it definitely attracts therapists who are passionate about women's health, which is amazing and awesome. But yeah, there's never going to be enough supply for the demand. And that's a problem. I mean, the other thing that I think is super interesting about the role of pelvic floor PT is, and correct me if I'm wrong, but if you look at all the meta-analysis and the Cochrane reviews, peripartum pelvic floor PT just prophylactically has never been shown to have any benefit. That's not to say if there's like a diagnostic issue, like a true issue therapeutic benefit. There is, and we all do it. But people sometimes are self-flagellating, coming in and saying, oh, I should have done some more Kegels before delivery. And you're like, well, it really doesn't help.
Right. Well, and I think something that's tricky there is that there's so much human element with physical therapy, right? Like they spend 1 hour a week or 1 hour every other week working, one-on-one with a physical therapist. But I mean, it's really the time the patient puts in outside of those sessions. And that I think is where it really makes pelvic floor physical therapy challenging to study the impact sometimes because of that human element.
Yeah, it's true. And I mean, and if you look at the optimal trial for urogyne, I mean, perioperative pelvic floor PT, pre-op, post-op around pelvic reconstructive surgery didn't make a difference.
Right.
Same with the slings.
Yeah.
It helps with that like subgroup that have urge, basically, is what it shows.
But with social media and ads being served to patients and TikTok and everything else, I'm just curious, what is the role going to be of these home pelvic floor trainer devices? And especially as they become more popular, can patients comply to it more? There's been some good studies that have looked at different devices like for stress incontinence. And I think the one thing that's kind of cool about these studies is that they can actually see how compliant patients are with the device. And even one of the studies, they asked patients how compliant they thought they were, and then they audited the device, and the least compliant patients definitely rated their compliance higher than what it actually was. But at least it then creates some control of okay, when people do pelvic floor muscle, regimens regularly, what kind of benefit do we actually get?
Well, they're not alone. I mean, I always say surgeons always overestimate their volume, underestimate their EBL and their operating room time. Mark
Oh,
knows
for
this.
sure.
I've said this a million times, but he knows
Yeah.
because he wears the OR and the CMO hat. So it's like we're all like delusional. I mean,
I know.
there's
Just
no,
show me the data. It's fine. You can
yeah,
tell
exactly,
what you think you know, and let me just tell you what it is.
Right.
exactly.
Let me ask you a question on the LDRs. So when there's a tear, how much does the actual repair at the time? I know that there's, occasionally Euro guys get called in. It's not really like the on-call situation at every place, but certainly it's something that these can be complex repairs. And how much do you think the repair at the time impacts the long-term outcome from a third, fourth degree tear?
I mean, that's an interesting question. So, I mean, there has been some data looking at this of who does the repair and can that affect outcomes. And there is some data suggesting that like repairs done by midwives on more complex tears can be associated with higher rates of wound complications. That being said, I mean, at least at our institution, our midwives do a great job of evaluating the patient, but then we'll call in higher order, trainee or physician to do the repair. I think that, again, those in the labor and delivery room is the least optimal situation. I think it is a shot to definitely do the repair well. And so, I mean, I advocate if it's a complex tear, move the patient back to the OR, get proper equipment, get better analgesia, get improved lighting, and then do the tear to the best of your ability. I think a digital rectal exam goes a long way as well to just really evaluate the anatomy and know what you're working with and make sure that you don't miss something. So in that regard, I do think that there are opportunities when you do have the tear to do it the right way the first time. There are also, the ACOG practice bulletin recommends a dose of antibiotics like a cephalosporin if you have a third or fourth degree tear at the time of a repair, unless they've received antibiotics for, chorio or something in labor already. And I think that has been shown to reduce the risk of wound complications as well. So, I mean, there certainly are things in the provider's arsenal that they can do to do it right the first time.
I want to make sure it's clear. I'm not saying this with any judgment. Like, as someone who did a 4-year OBGYN residency and I've done my share of deliveries, like I think I saw 1 fourth degree. Like it wasn't something I saw a lot, let alone, and that was, we delivered boatloads and boatloads of babies while we were in residency. And it just wasn't something I did a lot when I was in training. And so when you get out, again, it's just not something you see. And what is the rate of third or fourth degree repair in a SVD?
So, I mean, depends on what study you look at. I think 4 to 11% is the incidence of a third or fourth degree tear. I think it also depends, are you at a center that does a high volume of operative deliveries? Because that certainly increases risk. But you're right. I mean, the point you're making, Mark, is spot on because, I mean, we know that there are studies saying that trainees leave residency and don't feel comfortable managing advanced tears because of the infrequency with which they happen. I mean, and you're right. If 80% of women have a tear during a vaginal delivery, the vast, vast, vast majority are going to be first and second degree tears. So how do you get good at something that you only do a couple at?
How do you recognize it? How are you comfortable making that assessment to even know? I mean, I say this with some distant memories of going, I don't even know what I'm looking at. And then someone comes and goes, oh, but it's to say it's not an easy thing.
No, it's certainly not.
I do remember one study just on going back to technique. There's Green Journal study, and they looked at overlapping versus end-to-end. And actually, surprisingly, end-to-end at the time of delivery did a little bit better. I don't think it was that big of a difference, but this was maybe 10 or 12 years ago.
You're talking about external sphincter?
Yeah, for external sphincter repair. But we usually use the scar to do an overlapping if we can, but it's associated with a little bit more dyspnea with a delayed repair, I think. I think that here at least we don't get called in for third or fourth degree tears, but I have colleagues who say that they get called in all the time. And this just brings up that question of like you're saying, I mean, if you don't see that many, do you feel comfortable doing it? And then it's just that is a training problem creating itself as well. Obviously, we don't want to have more 3rd and 4th degree tears just for training or what have
Right.
you. I mean, I think prevention is key, and we're going to do that. But it is interesting. Like, if you look and you forecast what the training is going to be like for 3rd and 4th degree tears, it is good for the residents to train and know how to do it, right?
Right. I mean, we have opportunities educating trainees on anatomy. I mean, we just actually this past week did a urogyne kind of sim session for all of our residents. I think sim goes a long way where, you use the kind of low fidelity models of how to repair and what the anatomy is so people get used to the steps. I think, just giving people the tools in their armamentarium, like, okay, first, if you don't know what's going on, start with a rectal exam and then get a sense of the anatomy, get some irrigation or suction, even if you're in the labor and delivery room, and then know what to ask for. And so I really thought it would be interesting to have like a pick sheet that in the labor and delivery room to make it easier for people. Like, okay, we have a third degree tear, like grab the kit, grab the antibiotics, with extra tools and the suture you need to kind of make it almost a little bit formulaic. Obviously, again, I hope that it comes off with the utmost respect that I have for what obstetricians do, because those are really, really complicated, tricky repairs, but to just kind of standardize it and make it easier. So I think sim and just really good foundational knowledge can be really helpful for going a long way with this, situation that is not that common.
Well, I agree with you about, I love the patient ed that you did, because I think a lot of this about surrounding pregnancy and childbirth is, and just surgery in general, is managing expectations, not just surgery, medicine, because these are things that can happen with a normal delivery and nobody did anything wrong. It can happen. And people are educated that this could be possible sequelae. I think people naturally go into surgery with knowing or expecting that sometimes things can go wrong. It's intuitive, but I don't think that that's just the same thing with labor and delivery. And then what you're saying about the best practice alerts on the EMR, about the pick sheets, about the education, about getting the antibiotics, about, there's all of these protocols, and the protocols are, I know people don't like protocols sometimes because it's formulaic, but I think formulaic saves lives. And I think Mark is in the middle of doing all this quality work, I'm sure, all the time, but we just rolled out a sepsis sepsis epic set, the labs you're supposed to order and the things that you're supposed to do in order to treat the patient. So I think that like all of those things are a really good point. I mean, I remember when I was a resident, every postpartum hemorrhage, 10% of deliveries end up in hemorrhage. It was like the next time was like the first time. Every time you went up to the floor, nobody knew what was going on. Nobody could start an IV. There wasn't equipment available. Like if you just had like a set you could just grab,
Well, no, and then we're like, oh man, we were heroes. We like swept in and fixed it all. Like, yeah, but you didn't have to. You could have completely been ready for that like ahead of time. And I always use this analogy. There's a baseball player, Jim Edmonds, who always won Golden Gloves for making these great diving saves because he was always out of position. Like the other guys are just standing there and like catch the ball because they're where they're supposed to be. And he's like running to do it. Like set yourself up to succeed, be in the right place, have everything prepared ahead of time. We don't need to be heroes. Just it should be boring and formulaic and just do it the same way every single time. And when there's a variation, when there's something outside of that, you recognize it because it's outside of that norm. But man, people love to just do it their way. And it's something that, Amy said, I'm a much more of an administrative role these days, and getting people to do the right thing is a challenge.
Well, also when you're in the thick of things, it's hard to remember all the things that you need.
For sure.
You know what I mean? Because it's like there's a lot of blood happening. There's a lot of chaos. There's screaming. There's like 20 people in the room. So like making this as easy as possible in a chaotic situation is key. And that's why the sim for doing obstetric emergencies, the sim for the beef tongue model for the lacerations, I think is all key. And so I think that, and then just educating the whole team on what to do is also key. So I think that these are all little things that very difficult in practice to do. Like you created a team and you created awareness. And I know when you were just leaving as I was coming, but you were so passionate about it. I think your passion for this was infectious. And I think that's why also people got on board, because people understood that there was a gap. I mean, there's not enough of you. You probably could do this like your whole practice, because there's just so many people.
Yeah. I mean, there ends up being way more people than what you would think. And so, I mean, I was so humbled when I started it at Cleveland Clinic, and it was such a success that I knew I kind of just had to like do a beta model and, rebuild it at Ohio State. And same thing. I mean, we have seen some really interesting patients. We have seen a lot of uncomplicated patients, but those patients leave with education and they feel empowered. And actually, Katie Probst and Cecile Ferrando and Alexander Newtitis just published recently like a qualitative study where they interviewed women who had OASI. And the big three themes were their desire for pain control, for multifactorial support, and then OASI knowledge and awareness. And, that's some of the things that we are addressing with the clinics, which is really cool because it kind of matches up the needs of what patients want and what we're able to deliver.
That's wonderful. And, it is a testament not just to your passion and hard work, but also that you're able to build it in a way that's sustainable, and the fact that you've left and gone somewhere new and it's still going where you were. And that's something that is so valuable to me, to know that when folks are out there building things, it's not just, it's only me, only I can do it, right? You're seeing it in a way that like, let's do it in a way that other people feel a part of it. We build the team, and even when you step away, it's sort of self-sustaining. It's a hard thing to do. It's something I value personally very much, especially in what I do today. But it is a testament to your efforts, to your hard work and your commitment. And it's very cool that you've done what you do. And thank you so much for your time and for coming on the show, because I think it'll allow some of our listeners to think, well, I should be able to do it where I am too. And I think it's something that patients need. And there's no question there's a gap here. So thank you so much for talking about your program and all the work that you've done. And tell everybody at the Ohio State that I say hello.
I will. And thank you so much for having me. And truly, one final little plug. I mean, anyone can do this. So, if you are someone who's listening and this is something that's interesting to you, I mean, I have helped other people. I would be happy to help you kind of figure out what a model could be. So just reach out to me. I'd love to help.
For our listeners, they can contact the show, and we can always make that connection as well. And we can put a link to your website in the show notes as well, just so people can see what it is that you do. And what a pleasure.
Thank you so much for having me.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.